lips. So this is what oral cavity is. And you know what oral cavity is. You know what cavity is. Everybody knows what cavity is, right? Cavity is a space. Virtually, it means a space. And oral cavity means a space in the mouth. Okay? It's a space. So you should understand when you say of oral cavity, that means it's a space. What kind of a space? It's a space in the first part of digestive tract or alimentary tract. You know, digestive tract is, excuse me. Okay. Why not? Something wrong. Just can you wait for a second? There's something wrong, technical problem. Okay, go on to slide. Just a minute. Can you wait for a second? Then back off one. I just share them. Okay, slide. Same. There's a mistake. Oh, okay. This one. Okay. Now, sorry for the trouble because there's some technical problem. Well, if you look at this slide, you can see the alimentary tract here. Okay, this diagram shows the alimentary tract, and then you can see a cavity here that is basically made for ingestion of food. Okay, and once you ingest the food, it will be grinded, down into fine particles. Because as you look into the oral cavity here, you have different types of teeth here, different classes of teeth rather. And we say they are teeth, but they are different types. They are different classes, and accordingly, they have different functions. Now, if you look at the anterior teeth here, they are cutters. They cut. That means if you take a piece of food, they cut into pieces, small pieces. And then you have a piercing tooth here, canine. They pierce meat, and then you have grinders. Once these teeth, they cut food particles into small pieces, they grind down, okay, like a meal. Okay. Now, like a meal, they ground down and they break down into small pieces in order to increase the surface area for the action of digestive juice. Okay, and you have, of course, their principal salivary glands as well as accessory salivary glands throughout the mouth, everywhere here, labial, buccal, palatal. Okay, so there are so many accessory glands, and also you have a palatal gland, you have submandibular gland, and you have sublingual gland, which all of them open into the oral cavity. So there will be secreting mucus as well as salivary enzymes. So what happens? These salivary enzymes and the mucus, they will convert the food into bolus. That's the preparatory phase of swallowing, if you remember it, okay, your physiology, which you did in your first and second years. Now, once you grind it down, mixed with mucus, the food will convert it into bolus, as well as, because there are some digestive enzymes, salivary amylase, ptyalin, all those things. So that there will also be a partial digestion of the food there. There will be not complete digestion, but there will be partial digestion. And once the bolus is made, what happens? The tongue and the palate will propel that into the pharynx. That is what is the first stage of swallowing. We call that as an oral phase, or we also call that as a buccal phase. So what happens? The next thing what happens is the swallowing. This is the bolus of food, and it is propelled down into the pharynx here. Okay? So if you consider all these things, now you can say the functions of oral cavity is the ingestion of food, is the mastication of the food, is the partial digestion, and also help in swallowing. Okay? These are the basic functions, but there are some more important functions as well. For example, articulation of speech. Okay? What is articulation of speech? How is speech produced. See, now I'm speaking to you here in language, English language, and you are understanding me, okay? So how are these sounds produced, Basically, the sound is produced here in the vocal cord, right here in the vocal cord, in the larynx, and that sound, when it comes out, it will be modulated or it will be articulated in different parts of our oral cavity, right? Starting from velopharyngeal sphincter, where there's uvula, and then before that you have a tongue, and you have a palate, and you have teeth, as well as you have lips. So different, sounds will be modulated in these different regions, and they will produce different types of speech. Okay, so articulation in speech is another function. If you don't have teeth, if you don't have tongue, or suppose you have a tongue tie, or you have some kind of, somebody suffering from cleft palate, when there's no velopharyngeal normal function, probably the person's is not going to be clear. Okay, it's not correct. So articulation in speech is another thing which is very, very important function of oral cavity. Okay, now just a minute, I'm coming back again. Okay, now, so after articulation of speech, okay, after articulation of speech, that another important function is, can you guess what this is? You can see the mouth open here, okay, mouth open, and this kid is having his respiration through the mouth. Now, you can well imagine a situation when you have nasal congestion. There's a swelling of the nasal mucosa, or you have a deviation of the nasal septum, and you're not able to breathe through nose. What happens then? Then you have to breathe through mouth. So mouth also, or oral cavity also functions as an accessory air passage. That's another function. And at times, sometimes, defense. Okay, somebody attacking you, you can use your teeth to bite and then get out of that attack. Or even offense, when you have to fight something, offense or defense, whatever you would like to call that. So these are the all basic functions. And to summarize that, you have mastication, partial digestion, deglutition, accessory air passes, articulation of speech, and sometimes defensive. Is that clear? Okay, now we'll move ahead. Now, when you say oral cavity, because the dental surgeons, oral surgeons are supposed to know their territory, Now, you can well imagine the situation between India and Nepal right now, the problem, because the border was not clear. Okay, now what problem are we having right now? We're having a problem between India and Nepal regarding Limpiadura, Kalapani, and all these things, because that border area was not clear whether that belongs to India or that belongs to Nepal. We are very much clear that that belongs to Nepal as a Nepalese with all the proofs and everything, but then still there's a controversy. So as a dental surgeon or as an oral surgeon, we need to know what our territory is. So we'll not be encroaching upon somebody else's territory, for example, ENT surgeon's territory. Similarly, the ENT surgeons should also know their boundaries, so they will not be encroaching upon our territory. So no confusion there. So let's define the boundaries of oral cavity first. Okay, now talking about the boundaries, there's anterior boundary, lateral boundary, posterior boundary, and it has a roof, and it has also a floor. Now, anterior boundary is formed by the lips. Okay, the lateral boundary by the cheeks. Okay, now if you look at this diagram, you can see here, this is the posterior part of the tongue. This is what is called oropharyngeal smooth, which is formed by the palatoglossus muscles. Okay, so this is the anterior border, this is the posterior. We'll talk about this in more detail in subsequent slides, but for the time being, what you should understand is that lips anteriorly, and the cheeks laterally, and then posteriorly, palatoglossus arch, and then you have the roof here made by the palate, and floor and tongue. Okay, I'll discuss that in more detail. Now, before going to the borders in a little bit more detail, let's discuss what are the compartments of oral cavity. Once you have said that from lips right up to the glossopharyngeal arch here, okay, that is the boundary between throat and mouth, glossopharyngeal arch here. So this is oral cavity, okay, and then we have teeth in between, and we have the alveolar bone in between, alveolar bone or alveolar arch in the form of arch in the maxilla as well as in the mandible here. Now these alveolar bars and teeth, when you close them, when they are in contact, so this oral cavity will be divided into two compartments. This is compartment number one, smaller one, slit-like. This is bigger one, which contains tongue. Now this slit-like space of the oral cavity, which lies between the lips and cheeks on one side and teeth and alveolar arch on the other side, that is what is known as oral vestibule. Okay, so that is oral vestibule. Can you see that? You have lips here, you have cheeks on the side. So this is space just outside the teeth and alveolar arch, but inside the lips and cheeks. That is what is actually oral vestibule. Okay, now behind this teeth and alveolar arch here, behind these teeth and these gums inside, this is what it is. That is oral cavity proper. Okay, so these are the basic two compartments of oral cavity which you should know. Now, see, once you have opened the teeth, and you can see the oral cavity from here. So this is vestibule and this is oral cavity proper. So we'll study or we'll discuss, I'll explain a little bit more detail the boundaries now. See, lips anteriorly is closed and cheeks laterally. So can you tell me which actually muscles will make this lips? What is lip actually? It's nothing. It's a muscular. It's a muscle covered on outside by the skin and inside by the mucous membrane. Simply, you have which muscle? You have orbicularis oris muscle. Okay. Now, if you look at this diagram, you can see the orbicularis muscles right here. Okay. And you have, of course, levator muscles, you have repressor muscles, all these things. I'm not going to go into detail that we have already studied probably. But on the lateral side, also you have buccinator muscle. So that forms the cheek. Okay. Right? Just to give you some idea about that one. Now, if you look at the posterior boundary, here, what you can see here, you can see the uvula of the soft palate. This is soft palate. Okay. This is soft palate. You have the uvula, a conical extension downwards. This also is made up of muscle as well as mucous membrane coverage. And then you can see here the tonsillia, tonsil. Okay. Tonsillia. Now, when there's a depression here, palatine tonsil fossa or tonsillar fossa, you can see one anterior boundary and the other one is posterior boundary. The anterior boundary or fold is made by palatoglossus arch. This is called palatoglossus arch. And the posterior one, you can see another arch over here. That is what is known as the palatopharyngeal arch. Now, the depressed area between this anterior or palatoglossus arch and the palatopharyngeal arch, that is what is actually tonsillar fossa. Now, as long as the oral cavity is concerned, the palatoglossal arch forms the posterior boundary of oral cavity. Okay, so that is our limitation here. This is the limit. This is the posterior boundary, and you have uvula, and again on the other side you have again palatoglossus arch. Okay, we'll talk about the muscles there in a little bit later. I'll explain that to you. Now, if you concentrate here, okay, you have a palatoglossal arch and palatopharyngeal arch here. I just wanted to show you the muscles. This is palatoglossal muscles, and we have removed the mucous membrane from here diagrammatically. So this is palatoglossal muscle, and this is palatopharyngeal muscle, which goes down to the side of the larynx. Now, this depression, this area is what is actually tonsillar fossa. Okay, and this is the posterior boundary of our oral cavity on either side, and this is tongue, as you know it. Okay, is that clear? Okay, now. If you want to see the same in a more lively form, I've got one more diagram for you here. Now this is uvula, this is palatoglossus arch, this is palatopharyngeus arch, and this is tonsillar fossa. Same thing here, and this is tongue. So when you examine your oral cavity from now onward, probably you will be focusing on these things as well. Okay, that's great. Okay, now, so let's talk about the roof of the oral cavity now. Okay, you have been opening your mouth and you have been seeing into the mirror. You have seen mouth of so many patients probably during your clinical duties. But I don't know whether you have been very, very critical on examining what are the different structures there. You know the teeth already, okay? You know the teeth already, and you should be able to know the normal anatomy of the teeth to know when you see an abnormal teeth, okay? You will be learning that in due course of time in the subsequent class But then you have the cutting teeth here, as I said earlier. These are like a knife-edges. You can see knife-like edges, and you have a conical edge piercing meat, and you have some kind of cusp elevated, and then depressions. And with the help of temporomandibular joints, when they grind down food particles into smaller pieces. So these are the teeth. Now, surrounded, you have a gingival margins. You can see the gingival, gum tissue, soft tissue. This is an epithelial tissue. Of course, underlying connectivity is there, mucoperiosteum. And then see the collar. They are very tightly, they are very tight form. And then they're pink in color. Okay, they are not red in color. Remember, the gingiva is not red in color, which most of the people think. They are collar pink in color. Okay, so you see the tightness here, and then you see the collar pink here. Okay, they are, of course, from outside, they're all keratinized, stratified squamous epithelium. Okay, that's why, because of the keratinization, they look more pink, because the blood vessels down there are not reflected. The red color of blood vessels are not totally reflected here because of keratin. But whereas in the mucous membrane here, they look more reddish because of the blood vessels, which can be seen from outside. Now, you'll see here from here to here a mid palate and dry bay. Actually, when the two halves of the palate they meet each other, there's a small depression, and on either side of the depression you have a small ridge. So that ridge runs right from here, this point, to the back of the teeth. Now that raphe is known as actually mid palatal raphe. Okay, mid palatal raphe. And now another very, very important structures here is incisive papilla. Slightly raised tissue with underlying connective tissue running anteroposteriorly, just behind the central incisors. Now this raised papilla is known as incisive papilla. Okay. Now this incisive papilla, why? What is the importance? Because this overlies a small foramen here known as incisive foramen, through which the nasopalatal nerves comes out and innervates this part of gingiva, right from canine to canine, this area. Okay, so the importance, clinical importance here is, if you want to do a surgery of this part of the gum, or you want to extract this tooth, you need to anesthetize here. You can give a local anesthesia right here, so that this area will be numbed. That's only, you have to give only when you have to treat this anterior teeth from canine to canine, because from here, canine onward, premolars, and all this will be innervated by different nerves, which we'll be talking afterwards. Okay, so this is incisive papilla, a raised connective tissue overlying incisive foramen. Okay, now another important structures in the oral cavity, in the roof of the oral cavity, you can see some transverse ridges here. Okay, some transverse ridges. Okay, just behind the incisive papilla, running transversely, they be about 5 to 3 to 7, 4 to 7, not many, but they are very rough. During swallowing, actually, this rugi helps the tip of the tongue to be stable during the first phase of swallowing. Okay, so these are called palate rugi. Now, let me also share one more information regarding the rugi to you. See, rugi, the patterns of rugi in different individuals, they are very, very unique, like the fingerprints we have. So fingerprints are very, very unique. They're different in all individuals. Okay, so in forensic odontology, these patterns of these rugi are used. Okay, we call that as a palatoscopy or palatal rugoscopy. Okay, if you have a record of this rugi, okay, if you have a record of a person of this rugi, and when somebody happens something, somebody dies, and you are not able to identify that person, you can match this, okay, and you can identify like the fingerprints. But fingerprints, this is more important than fingerprints, because fingerprints usually when there's a burn cases, what happens? The fingerprints will all be gone off. Okay, but usually this area becomes very, very safe. Now see, if you compare this alone, there's a 70% matching rate only with the rugi. Okay, but if you match with all the jaws here, almost 100%. So you can well imagine how important the pattern of rugi is, the importance of rugi is. Not only it helps in the swallowing, but also it helps the forensic odontologist to identify a dead body. Behind that, there's a soft palate, which we'll be talking in due course of time. Now, once you remove the gingiva, once you remove the gum tissue, what do you see actually? You can see the bone here, bony palate here. Okay, you can see the bony palate here, and then you have one foramen here that's called incisive foramen. I talked about that just now. This actually opening for the nasopalatine nerves, and then you have this palatine process of the maxillary bone, and then horizontal plate of the palatine bone. So together these two bones actually they form the hard palate, and from here the soft palate starts. Now here you can see a major foramen here, greater palatine foramen, from where actually the greater palatine nerves and vessels come and they move forward, and then that nerve innervates the area from this point right up to this point. Okay, so ahead of that is the area of nasopalatine nerve. But from this area, from premolar to right up to the molars, this area of peristome is innervated by greater palatine. And then behind that, you can see some small foramen that is called lesser palatine foramen, through which the lesser palatine blood vessels, neurovascular bundle comes up, and the lesser palatine foramen, the lesser palatine nerve actually innervates the soft palate. Okay. Can you hold for a second? He's extending time. Continue with that. Okay. Until the time extension. Okay, this budget. Okay. All right. So I'll continue, and then my friend here, the technician, will be extending time once it is over. Now, this is the soft palate diagram. This photograph is showing the soft palate here. Hard palate is right up to this point. Okay, from here the soft palate begins. Soft palate actually, as the name says, is a soft. It doesn't contain. It has a muscles as well, and then you can see a conical extension here, as I mentioned earlier. This is the uvula, and this uvula is nothing but it contains muscles as well as mucous membrane on the upper side as well as in the lower side. And then I've already talked to you about the tonsil and then the glossopharyngeal nerves. So this is actually this forms the posterior boundary of our oral cavity as well. Now, what are the muscles which form, soft palate? If you want to name them, we have done that in your first year. But just to revise that, you have a musculus ubili. That's the intrinsic muscle. See, this is soft palate. You can see that this is soft palate. Okay. So the musculus ubili is the intrinsic muscles of the soft palate, and then there are extrinsic muscles like tensor belli palatini, levator belli palatini, palatopharyngeus, and then palatoglossus. These two muscles was from here, if they are going up to elevate them, and then these two muscles will be going down from here to the tongue and pharynx. Now, in order to understand the muscles of soft palate, you have to understand the structure which is just attached to the posterior border of hard palate. Now, this area, you can see this area, is a connective tissue, aponeurosis. That's called palatal aponeurosis, which is connected to the posterior margin of the palate. Now, here, the other muscles are attached to this. Okay, the muscles are attached to this. So, I have got another diagram for you to make you understand all these muscles. Now, see this. I hope you can understand this muscle, this diagram. This green here, this green thing here is the palatal aponeurosis I just mentioned. Okay, this is the palatal. This is nasal cavity. You can see this is nasal cavity down there. Now in front of this is palate, hard palate. Here this is soft palate, a palatal aponeurosis, and then you have a uvular muscle, intrinsic muscle, uvular muscle. Okay. Now from here you can see the two muscles going up. This is levator valli palatini, and this one is tensor valli palatini. This stretches the soft palate, and this elevates. You see, during swallowing, when you need to close the nasal compartment, then probably this muscle will contract and lift the soft palate up and close the nasopharyngeal aperture. Okay, so that the food can pass through it. It will not go into the nasal cavity. Similarly, we have two muscles going down here. This is palatopharyngeus, okay, posterior arch, as I mentioned you earlier. Palatopharyngeus, this also comes from the soft palate and goes down to the lateral side of larynx. And then this is the anterior arch forming the palatoglossus arch. You can see the palatoglossus muscles, which also originates from here and goes down to the lateral side of tongue, and then mixes up with the intrinsic muscles of the tongue, which we'll be discussing in due course of time, very shortly rather. And I don't want to go into detail because I think you have already read it, your ENT or anatomy or so many places. I just to recall this, these muscles, when origin and insertion, and then what are the nerve supplies, and except for the tensor valli palatini, which comes from the mandibular division, rest of the things they come through the nerve innervation comes through the pharyngeal plexus. That means vagus nerve. Okay, the vagus nerve means the 10th cranial nerve. Okay, so you remember that as such. Okay, the functions you know already. That's you must have studied in the ENT, or you will have to study in the ENT, whatever. But just to give you an idea that the muscles involved in the soft palate are basically the musculus ovili, intrinsic, and then other four muscles, tensor valli palatini, levator palatini, they are upwards, and palatoglossus and palatopharyngeus, they are going downwards. Okay. Now let's be familiar with the floor of the mouth also. Okay. Now what you see here, you can see a fold of mucous membrane. You can see a fold of mucous membrane here. Okay. All right. So this fold of mucous membrane, anywhere, the fold here, the fold of mucous, we usually term that as a frenulum, F-R-E-N-U-L-U-M, frenulum. And the plural term for that is freni. Okay. Now here, if you look at the floor of the mouth, you see a fold of mucous. Actually, the function of the frenulum is to restrict that particular organ which it is attached to. For example, here it's tongue. This lingual frenulum attaches tongue to the floor of the mouth and to the entire part of the dental pouch. Now it will restrict it. It will not allow it to go so far away. Okay, it will restriction. Okay. Now, if you look at here in somewhere here on the floor, you can see a raised papilla-like thing here. Okay, raised papilla-like thing. This is actually the open more than necessary actually, and then this is the papilla, lingual papilla, where the opening of submandibular salivary ducts, and this is raised tissue which defines the location of sublingual salivary glands, and then you can see multiple openings here through which the saliva coming out of sublingual gland into the oral cavity. And sometimes what happens, if you have a short lingual frenulum, you have that's called tongue tie, and if that impairs the speech articulation, probably you need to do a frenectomy over here. Okay, frenectomy. So that is lingual frenulum, that is sublingual papilla, and that is lingual fold. And what I was mentioning just now was the deposit. Okay, so when you eat food particles, they get deposited on the tooth surfaces, and then in the beginning they are soft, but later they become hard, which we call as a tartar or calculus. Okay, once that becomes hard, you will not be able to clean that. Okay. Now, calculus is very, very common in the lingual surfaces of lower teeth. The reason is because of the opening of this saliva, the source of calcium and phosphate for the calcification of the soft deposits. Okay, that's very, very important. You have to know this. Why calculus deposition is more here in the lower lingual surfaces. We'll also talk about the upper when you talk about the extension talk afterwards. But for the time being, you will just remember that. And you can also see some deep lingual veins here for your information. You know that already. Deep lingual veins over here, you can see it here, just on either side of the lingual frenum. Okay. And the floor, of course, the floor is basically made by the mylohyoid muscle here. You can see that from the hyoid bone to the lingual surface of the mandible, mylohyoid ridge. So this forms actually the what you call the base of the floor of the mouth. Mylohyoid muscles, remember that. Now, if you concentrate this diagram here, this is the sagittal view, you can see the mylohyoid muscles right here. Okay, mylohyoid muscles right here. You can see the incisors, mandible, cross section of the mandible here, and you can see, as I mentioned just now, the sublingual gland here. Okay, and then you can also see the submandibular gland. And you see here, the submandible has a superior part and the inferior part. Inferior part is down there, but the superior part is above the mylohyoid muscles here. Now, when you examine, when there's a swelling in the floor of the mouth or in this area or on the floor of the mouth, you need to do a bimanual palpation. Okay, when you do a bimanual palpation, if the bimanual palpation is positive, probably that swelling is because of the submandibular gland. But if the bimanual palpation is negative, then probably that is because of the sublingual gland or maybe some lymph nodes, etc. Okay, so this is very important clinical examination, intraoral examinations. I don't know if you're doing that already. Okay, otherwise from now onwards you can try that when you do the examination. Now let's talk about the tongue. Okay, let's revise the tongue. You must have studied tongue already so many times, but let's revise it. Our tongue basically has a dorsum, that's why I call body, dorsum of the tongue. This is apex, and this is the root. The last part of the body is called the root. Okay, so basically it has you can see here in the diagram sagittal section. This is root, this is dorsum of the, and this is tip. So this is a muscular organ. It's a muscular organ, very, very mobile and sensitive, and very, very important functions for so many things actually. Articulatory speech, making a bolus of the food, and there's so many other things, taste, etc., articulation of his speech, and etc., etc. Now let's go into the tongue more deeper, more deeper. Now this is tongue, this is the tip of the tongue, and this is the posterior border of the tongue. Okay. Just a minute.
Yes, sir.
Ivan Basay Sonala. The different parts of the tongue. Okay. See, this part is called dorsum of the tongue, and this is called the tip. Okay. So when you view from the above, and then there is a V-shaped groove here, right here. Okay, V-shaped here. Now this is called sulcus terminalis, and then at the tip of this V, you have a small opening that is known as foramen secum. What is foramen secum actually? That is actually vestigial part, which actually indicates a place for the earlier thyroglossal duct formation. Okay, Actually, thyroglossal dog forms from this point, but later this disappears. This becomes disconnected. Okay. Now, this sulcus terminalis actually divides the tongue into two parts: the anterior 2/3 and posterior 1/3. Okay. So this is anterior 1/3, 2/3, and then the posterior 1/3. And then the back part of the posterior third is what is actually known as the root of the tongue. Now, this is very, very important because their origins are from different parts of the pharyngeal arches. You know, if you remember your anatomy, the pharyngeal arches, the origin of muscles, origin of the bone, they're all from the pharyngeal arches. 1, 2, 3, 4. Okay. So, because of the origin, this part comes from the different area, this comes from the different pharyngeal arch, and that's why actually the nerve innervation and also different. We'll discuss about that in subsequent slides. Now, one very, very important functions of the tongue is actually the taste. Okay, the taste, and the taste is because of the taste buds present in this papillae. There are some different types of papillae present in the tongue. Some are, like hair-like, like filiform papillae, we call that. Most numerous and abundant here, especially in this area. Okay, they're very small one, abundant, so many, maybe 1,000, 2,000 small. Okay, and then they are, the tip of them are keratinized, and because of that keratinization, actually they become rough. They feel rough. The roughness of the tongue is because of the keratinization in the filiform papilla. But remember, they are not synonymous to the taste buds. The papilla may contain taste buds or may not contain taste buds. Not all the papillae they contain taste buds. For example, the filiform papilla does not contain any taste buds. So this is not associated with the taste function at all. But the rest of the papilla, which are fungiform papilla, which is bigger than filiform papilla, which are much bigger and in the shape of mushroom, fungus actually. And then this is not keratinized. So they appear as a radius area here in the spots. I'll show you that diagram afterwards. And then foliar papilla, they are like leaf-like papillas. They are situated, located on the posterior sides of the tongue here and here. They are not present anywhere else, but they're present on the posterior lateral side of the tongue. They are in the shape of a tongue. Sometimes, people may say, may get confused. Your patient may get confused. I have a small wound here. They are not actually wounds, but they are the foliar papilla. And then here in the junction between the anterior and 2/3, when there's a sulcus terminalis here, just in front of that, and you see the biggest sized papillae. They are known as circumvallate papillae, and they are some from 4 to 8 or 9. They are very limited numbers, but they are all situated over here. Okay, so this is circumvallate papilla. So basically, we have 4 types of papillae: fungiform papilla, filiform papilla, foliate papilla, and then circumvallate papilla. All these are concerned with the taste except filiform, because this filiform papillae, they don't have a taste bud, so they cannot taste any food. Okay. Now, this is what the real diagram is. If you concentrate on this one, you can see small papillae here. These are filiform papilla. And then here you can see some radius, slightly bigger ones. Okay, you can see here, pointed out, rather big ones, because they are not keratinized, so they look more radius. So they are fungiform papilla. And on the sides here, posterior part of the sides, some leaf-like projections. That is what is actually foliate papilla. And here, the junctions between the posterior 1/3 and the anterior 2/3, you can see some raised papillae here. They are actually what is circumvallate papilla. Okay. Histologically, if you want to understand this, they're all conical forms: filiform, fungiform. You can see a little bit of fungiform, and then you have circumvallate, a little bit rounded, and then the different shapes actually. Okay, and then if you look at these diagrams, you can see some, taste buds here. You can also see some taste buds here, but you don't see any taste buds over here in the filiform. But you can also see the taste buds over here. Okay. Now let's discuss the different types of muscles of the tongue. Actually, as I mentioned you earlier, the tongue is actually a muscular organ. It's not a tissue, it's a muscular organ consisting of so many different types of muscles. It has, intrinsic muscles as well as it has extrinsic muscles. The intrinsic muscles are basically 4 types. They are superior longitudinal, they are inferior longitudinal, and you have transverse muscle fibers as well as you have a vertical muscle fibers. So there are 4 different types of. And then you have extrinsic muscles, you have genioglossus, hyoglossus, styloglossus, palatoglossus. Okay. Now, when you talk about the intrinsic muscles, you can see here above on the dorsum, just beneath our dorsum, you can see the longitudinal muscle fibers running from the tip to the posterior margin. Okay. And then here you can see the longitudinal, inferior longitudinal muscles. And then here you have vertical fibers and you have transverse. So when they contract, they perform different functions. For example, when this muscle contracts, it produces a kind of concavity here. Okay. And then when the vertical muscle fibers they contract, the height will be decreased. Okay. So according to their names, they have different functions as per their orientation fibers and the direction of their contraction. Now, similarly, if you look at the cross sections here, you can see the longitudinal fibers, inferior. You can also see transverse, and you can also see some fibers, vertical fibers. In this diagram, you can see this longitudinal, vertical. Okay. Now, regarding extrinsic muscles, you have geniohyoid. Okay, geniohyoid muscle is attached to the genial tubercles, superior genial tubercles rather. Okay, it's a fan-shaped muscles. Okay, it's fan-shaped muscles, and then when it contracts the posterior fibers, the inferior fibers, the tongue is protruded out. Okay. Similarly, you have so many other muscles like styloglossus muscle here, and then palatoglossus. They are directed upwards. Okay. So when they contract, the tongue will be elevated up. Similarly, you have styloglossus and hyoglossus, which are running downwards. So they will be retracting the tongues downwards. So together they perform different kind of functions according to directions. The attachment, as you know, according to the name, when you say genioglossus, that means from mandible to glossus means tongue. When you say hyoglossus, hyoid bone to glossus, it's easy to remember. Styloglossus means from stylic process to the tongue. Palatoglossus means from palate to the tongue. We have already discussed about the palatoglossus earlier. Now, this is the taste areas of the tongue. Okay, the anterior tip is concerned with the sweet, sides one with the salty taste, and then backward on the sides with the sour, and then posterior here, bitter. So you should remember all this area. What are the different areas of taste functions? Now, regarding the nod and innervation, the general sensation of the anterior two-thirds of the tongue is from the trigeminal nerve, the third division of the trigeminal nerve. So the taste comes through the chorda tympani from the 7th cranial nerve. Now, posterior one-third, both sensory as well as taste function is from the glossopharyngeal nerve, and behind the posterior third, the most posterior part is vagus nerve. And as long as the motor supply is concerned, all tongue muscles or the lingual muscles are innervated by hypoglossus, except the palatoglossus, where the innervation comes through the phalangeal plexus from vagus. Okay. Now, freni, I mentioned you already, the fold of mucous membranes. Apart from lingual frenulum, you have upper labial frenulum, you have the lower labial frenulum, and you have also buccal frenulum here. You can see that, and also you have lingual frenulum, as I mentioned earlier. The importance is that if there's a fleshy, kind of frenulum here and low attachment, probably that may create a space between these two central incisors. Okay, spacing can be caused by that. And then another important structure we have to know is that the small opening here, papilla with the small opening opposite the first and second molar on the buccal side, mucous membrane. That is what is actually opening of the stencil stalk. Okay, so you should also see whether that is normal or not. And then if you look at the surface anatomy of the palatal gland, you can see the palatal gland here, okay? And then this is, okay, masseter muscle, and then the top extensor duct just curves back in the anterior border and opens into the mucous membrane opposite first and second molar. Thank you very much.